next? Anticonvulsants. All right, let's do anticonvulsants. All right, so this too is going to be a little bit of a superficial jaunt through the anticonvulsants. If you want to get, really, really, really down in the weeds with anticonvulsants, you certainly can. I'm going to try to keep it general, give the sort of general toxicities to these overdoses, and then, if there's something that's sort of unusual or weird, testable, then I will try to bring that up as well. I apologize, this is a very blurry slide for some reason, but the point being that there's a lot of different mechanisms of action of anti-epileptics, sodium channel blockade, calcium channel blockade, NMDA, GABA, and then there's a whole bunch that we're guessing at, and we think that might be. I don't think there'll be many questions on this because a lot of them are actually unknown exactly what it is that is the anticonvulsant effect. So I don't think that you really have to memorize that type of stuff. But let's just start going through them. Carbamazepine, obviously its use has decreased a bit. In fact, in reality, almost all of these have reduced except for Keppra. That keeps going up. Lamotrigine is going up as well. But carbamazepine, lots and lots of toxicity. Still see this from time to time. Very erratic absorption. The symptoms in acute overdose, CNS effects as listed. I don't know why tachycardia is listed under CNS, but run with it for now. Seizures, QRS, and QT prolongation. I think that those are the big effects from carbamazepine. You can correlate serum concentrations with toxicity, but it is not. It's not perfect by any stretch. But in general, over 40, or that's about 3 or 4 times therapeutic concentration, is when you start seeing the altered, the significant reduction in mental state and seizures and hypertension. So what can we do? Activated charcoal if it's early. Basically most of this is going to be supportive care. QRS widening, we give bicarb for all the reasons we said before. QT widening, we use, we check calcium, potassium, mag. This is another one of the drugs that multi-dose activated charcoal, this is enterohepatic circulation, can increase clearance. This and phenytoin have a 50% reduction in half-life with multi-dose activated charcoal. So again, is that going to save their life? Probably not. What it might do is make them wake up much faster. And I think that is true for both carbamazepine and phenytoin. If it's safe to do so, then multi-dose charcoal is a good idea. And then I mentioned X-Trip, I think yesterday. If you ever need to look up X-Trip, you can just do X-Trip, EXTRIP to Google, and if you wrote X-Trip carbamazepine, it'll bring it right to the page. But what they say for hemodialysis for carbamazepine is if you have a concentration that's over 60, and like they always do, like any good intervention, if they're sick, they should get hemodialysis, right? Dysrhythmias, more than one seizure, if they're on a vent, all of those things are indications for seizures. I'm for hemodialysis. So, and I find this to be true for most X-Trip, is they have some very specific number, and then right underneath that number is all of the logical things that would make you want to do hemodialysis on a patient, which is essentially the definition of them being sick. So, which actually makes a lot of sense because you get to treat the patient and not a number, which is good. Oxcarbazepine is a similar medication to carbamazepine, and a lot of the Toxicity is, is very, very similar. CNS sedation and seizures, they can get much, much less commonly. A few other things that are reported: bradycardia, not super severe bradycardia, not like 12, but bradycardia nonetheless, and hypotension, just like carbamazepine. And the interventions, there's no X-trip on oxcarbazepine. There's also very little in the way of any literature, but given that it's pretty similar to carbamazepine, and given all of its characteristics, the light distribution, the protein binding, and all of those things, it seems like it's hemodialyzable. So clinically speaking, we would do that. I don't know that I don't think they can ask you that question on a test, because it's not quite proven, but I think it would be effective. So, gabapentin, despite the name, doesn't act on the GABA channel, which is super confusing, but it does cause mostly CNS sedation. So it's one of those weird things where the name says GABA, it doesn't affect GABA, but it kind of looks like a GABAergic agent. So it kind of works that way. Most people do fairly well on gabapentin. There are some people out there now that are abusing gabapentin, and actually a fair number of people who are abusing gabapentin. So most of those cases are still the same thing: CNS sedation, ataxia, kind of inebriation. So nothing more than supportive care generally. Now, on the other hand, lamotrigine can get super sick, and I think lamotrigine is one of those that is unique enough that it would be, and occasionally severe enough that would be a good target for questions on the exam. Lamotrigine overdose leads to CNS sedation, just like the rest. They all lead to CNS sedation, right? And ataxia, like most of the anticonvulsants. Ataxia and nystagmus is it's not universal, but it's pretty common amongst the anticonvulsants. What I think makes lamotrigine unique is they get myoclonus and hyperreflexia, which is, you can get that with phenytoin, you can get that with some other thing, but QRS widening and ventricular dysrhythmias can occur in large overdoses. So that, I think, makes it relatively unique. And I know that we've had a couple of, most of the lamotrigine overdoses do just fine, but we've had a couple of very, very severe ones, and a few deaths as well from lamotrigine. So there's not much in the way of, specific therapies. If their QRS is wide, we're always going to get bicarb. Hemodialysis, probably, we don't really know. And then I think this is a good case for lipid emulsion. In reality, probably all of the anticonvulsants make a case for lipid emulsion, but most of them don't get super sick very acutely like this does. Bad lamotrigine, they very, very quickly will have QRS widening, ventricular dysrhythmias, and kind of crash. And that's why I think lipid emulsion is probably used more commonly with that, as opposed to something like carbamazepine, which is sort of a slow, progression. They get intubated, and their blood pressure drops, and that happens over hours, so it's not quite as quick an onset. All right, levetiracetam, or Keppra, which at this point, thank goodness, is probably the most commonly prescribed anticonvulsant. In large overdoses, it can cause CNS depression. It can produce respiratory depression, but again, the overdose has to be very large. I think most of our Keppra ingestions do just fine. If you really took, 3 months supply, then there is a possibility that you can have a significant CNS depression with respiratory depression and require intubation and ventilation. But it's pretty unusual. No specific intervention. They don't have any cardiotoxicity. They just have to metabolize, and as long as they can get intubated and ventilated, they'll be just fine. As far as I know, no deaths, but you know, at least in hospital care. All right, phenytoin, our good old friend phenytoin, which thank goodness is not being used very often anymore. Although its friend phosphenotoin is still being used occasionally. More on that in a second. So phenytoin is the most common toxicity we see is chronic toxicity, where the patient is probably taking too much phenytoin and they come in with altered mental status, with ataxia, they can't walk, and they get admitted to the hospital, right? That is probably the most common way that we see phenytoin. Although again, phenytoin, specifically phenytoin use, is getting less and less common, thank goodness. If it's given IV, which you know, back in the day was you had to load everyone who had a seizure in the emergency department with IV phenytoin. It has a propylene glycol diluent, and if the IV phenytoin was given too quickly, they would very quickly get hypotension, QRS widening, ventricular dysrhythmias. That was probably partially due to the phenytoin, probably partially due to the propylene glycol diluent. But we don't see that anymore because they replaced IV phenytoin with IV phosphenotoin. Phosphenotoin is the water-soluble version, and it's just a phosphated or phosphorylated phenytoin. Gets quickly metabolized by blood phosphatases to phenytoin, and so the toxicity would be the same, except that you can give IV phosphenotoin rather quickly without getting that hypotension and dysrhythmias. Now, there is a limit, and usually those infusions are over a period of time. If it's pushed, you'll still get a similar reaction, but it's not from the propylene glycol, it's probably from the phenytoin with bradycardia and hypotension. Phenytoin has Michaelis-Menten kinetics. So if you recall, Michaelis-Menten kinetics is saturation kinetics. So at therapeutic doses, it has a relatively short half-life. Over therapeutic, it starts to overwhelm its ability to be metabolized. So your enzymes that are metabolizing get saturated, and then over that point, you are only metabolizing a certain amount of phenytoin over time. So it's no longer a half-life. It ends up being looking a lot more like ethanol, where you have a set amount of phenytoin being metabolized over a set period of time. The half-life, again, it's not really appropriate to use a half-life when the kinetics are saturation, but the time at which the concentration drops by half can extend into the days. And so when we do see these phenytoin toxicity cases where the patient can't walk, they've got ataxia, they've got nystagmus, they've got CNS sedation, they've garbled speech, and they can sometimes be like that for days and days and days. That is one, if they're awake enough to take multi-dose charcoal. This is one of the cases where we would give multi-dose charcoal. That can increase the clearance and allow them to wake up earlier. Again, the altered mental status is always the question. If they're so severely intoxicated that they're not able to protect their airway, then you can't give them oral activated charcoal. So that becomes the question. There is a protein binding to albumin with phenytoin, and there's this, and I think this is something that could definitely be a question. Say you have a normal amount of albumin, then your phenytoin, we know our phenytoin concentrations, and the phenytoin concentration looks like it's therapeutic. They're unlikely to have severe symptoms. If the phenytoin concentration is super high, then we know that they can that's too much and they can have symptoms. But if your albumin is really low, you're malnourished, you're alcoholic, all of the reasons why you might have a low albumin or chronically ill, then the phenytoin concentration, because the phenytoin concentration in your serum is both albumin bound and not bound, the phenytoin concentration might look like it's therapeutic, even though they have symptoms of toxicity. And there is this calculation you can do, which would give you a corrected phenytoin concentration. I don't know if this calculation would be on the exam, but I think the concept of the albumin correction. So if you have someone who has a very low albumin, instead of 4, it's 1. Your phenytoin concentration is going to be it's going to look much lower, even though they really have toxicity. So what can we do? You can do 2 things. Multi-dose charcoal is going to be the thing we do most often with these chronic phenytoin concentrations. Phenytoin is dialyzable. We rarely use it. I think we would probably use it. For example, we had a case years ago where they made a 10-fold dosing error with phosphonatoin in a small child. That child, because they gave a 10-fold dosing error, got up to a phenytoin concentration that we never see from people who take it orally. I think their phenytoin concentration was something like 700 or something like that. It was absurdly large. And so they got a phenytoin toxicity that we don't normally see, which is they were getting wide QRS, ventricular arrhythmias. And so that person, we would do hemodialysis for. But we rarely do it because usually the person has a chronic phenytoin toxicity, they're a little sleepy, they're going to be okay, and so we don't do the hemodialysis. But in emergent situations like an IV overdose, then we might do that. All right, just got a couple more pre-gabaline. Yeah. Oops, sorry, I lost my chat here for a second. I saw your question just for a second. Okay. Yeah, so agreed. So the question is, what's our discharge criteria for phenytoin toxicity? So this is like someone who's taking too much phenytoin, they get confused, ataxic, nystagmus. Honestly, if you stop giving them phenytoin, they're going to get better, right? So they're the worst they're ever going to be when they walk in the hospital, usually, unless they just ingested a bunch of phenytoin. So my criteria for admission and for discharge is kind of the same as can you walk, and can you walk safely? If you've because we're not putting them on a cardiac monitor, they're not going to have dysrhythmias in that situation. Again, an IV phosphatidylcholine overdose is a totally different story. That's a totally weird situation, and they can get dysrhythmias, but oral phenytoin doesn't get concentrations high enough to have dysrhythmias. So yeah, so I would discharge them as soon as they can safely be home. That's pretty much it. Yeah. I mean, again, if they can function normally without falling down, then I would, I don't see any reason for them to be in a hospital. We're not doing anything, we're not doing anything for them. Maybe multi-dose charcoal. But if someone's a little bit ataxic and they have, a safe situation at home where they're not going to fall down, then I'll fine discharging them. But if they're going to fall down, then obviously keep them insulated. Yeah, I know. It's like these medication errors, they mentally drive me crazy, right? 10-fold dosing error should never happen. There's probably five safeguards that have to be skipped or ignored or whatever. I don't want to like blame the practitioners, but like, there's just there has to be so many steps. But it's the same thing as like how are we still getting a neonatal resuscitation where the neonate gets the mother's medication? How is that even possible? Like there are like 30 systems in place that should never happen, and yet somehow it does. So yeah, I know. Nasty decimal, I like that. Okay, so we did pregabalin. Let's talk about tiagamine. Pretty much same thing. CNS sedation. Tiagamine has status or seizures or status epilepticus as they have to be pretty sick. They're not going to have seizures out of nowhere. They're going to have CNS sedation and tremor before that happens. So, if they're totally asymptomatic, they're not going to just start having seizures. There is one thing that is always seems to be mentioned in every paper or textbook about tiagamine, and that is they get myoclonus, and specifically they get myoclonus of the face. And so they get this grimacing when they have too much tiagamine. Never actually seen that, but, and by the way, tiagamine grimacing is also a pretty good band name. So I just wanted to say it out loud so that if that question comes up, hopefully that brain cell will fire. Topiramate is also, I would say, Topamax is also increasing. It's kind of Keppra, Topamax, lamotrigine taking over for what used to be occupied by phenytoin, carbamazepine, and valproate. But overdose, pretty similar to the same, of all of the other ones, CNS sedation, ataxia, nystagmus, myoclonus. You can kind of group all the anticonvulsants in that sentence, I think. The one thing that is unique about topiramate is it is a carbonic anhydrase inhibitor, and so it blocks the reuptake of bicarb in the kidneys. You have, and you can develop a hyperchloremic metabolic acidosis from that. And that would be a chronic effect probably, but it is possible in acute overdose. So that's another one of those things. It's like the tiagamine, grimacing, topiramate, acidosis. All right, valproate deserves a little bit of extra time, although again, its use is getting lower and lower, although it's starting to be used a lot off-label for a whole bunch of other indications that aren't seizures. CNS depression, certainly in extremely high doses, you can get respiratory depression and hypotension. The thing that keeps valproate makes it different from the rest of the anticonvulsants is the electrolyte abnormalities, hypernatremia, hypocalcemia, and metabolic acidosis, all associated. You can get a metabolic acidosis if you just take enough valproic acid. It's an acid, it's an organic acid. So, looking back at our cold mnemonic, your ketones would be normal, your BN would be normal, lactate would be normal, but you'd have this really severe anti-gap metabolic acidosis, and that's because there's valproic acid present. And then, of course, the hyperammonemia, which I'm going to touch on in just a second, and then bone marrow depression can occur. This only happens in people who are really, really sick. So it's not like we're sending people home when they get bone marrow depression, on day 4. This is the people who are still in the ICU and intubated with electrolyte abnormalities and hypertension. The specifics of the hyperammonemia are not super duper important, but let's just go through the basics, I think. So valproic acid binds to carnitine to make valproyl carnitine, and it carries it out of the cell. So the valproic acid and carnitine combine, they pulls it out of the cell, and so you have less carnitine. That causes a shunt from beta oxidation to omega oxidation, which is over here, and then you have inhibition of the conversion of ammonia to urea. So the details of this are not super specific, but I thought sometimes, some people learn graphically, and so that might help. But really the key is valproic acid is essentially chelating carnitine, and that leads to inhibition of the breakdown of ammonia, and you get ammonia building up. So what does that mean? We have patients who have hyperammonemia who aren't that sick. And sometimes, I'll go back to the graph. If they have hyperammonemia and they're not very sick, sometimes they get a little bit tired or a little sleepy from the ammonia. If it's really, really high, and then what we would do is give them carnitine to replace the carnitine that's been bound, and then normalize how they're supposed to do their oxidation. That would relieve the omega oxidation and relieve the inhibition on ammonia, and so you can metabolize ammonia again. So that's why we give carnitine. There are other cases where the patients are really, really sick and they have hyperammonemia, and in those cases, there's some evidence that giving carnitine can decrease how long they're unconscious or on a ventilator. There is one study that suggests that carnitine might decrease mortality, but it's not totally consistent across many studies. So I don't know if that's true or not, but it certainly seems reasonable to me. If you have hyperammonemia, that is a sign that your oxidation is not functioning the way it should. And we have a nice, easy antidote that can fix that problem. So I tend to treat with carnitine whenever the ammonia is high, because it's just going to normalize their normal function of oxidation. But I also don't have this hope that carnitine is going to make them all better if they're, hyponatremic and hypotensive and unconscious. Carnitine is not going to wake them up immediately, but it does help normalize their metabolic processes. So therapeutics is about 50 to 100. The concentration at which the symptoms get really, really severe is somewhere around 850. It's a weird number, I know, but that's just how it fell out. And above that number, we can expect to have metabolic acidosis and hypotension. And the treatments, multi-dose charcoal, carnitine, as I mentioned before, if the ammonia is elevated, and there's the doses there, and then hemodialysis. There's a number there that's worked out by XTRIP over 900. Why they got 900 and not 850, I'm not really totally sure. But again, they also give you that out where if your patient is really sick, then you can do hemodialysis, which I really do appreciate. If they're on a ventilator, which like everyone over, 700 or so, it's probably going to be on a vent. If they have hyperammonemia, if their pH is under 7.1, all of those are indications for hemodialysis. So we're going to, again, do hemodialysis on people who are sick and do hemodialysis on people who are not yet sick, but will be because their valproic concentration is very, very high. All right, bringing it home. Zonisamide, pretty straightforward seizures. All of the overdoses of these cause CNS depression. Many of them cause seizures. That's kind of the only thing that's unique about zonisamide. Nothing to do as far as treatment goes specifically. No hemodialysis. No specific intervention. And that was our journey through anticonvulsants. We pause and see if there's questions, and then Let's see, nasty decimal. I do like that. Speed metal? It would have to be like something energetic, right? You can't have like a singer-songwriter, you know. I'm nasty decimal and I'll be playing.
Hey Rob, I got a quick question. It's kind of a
Yeah,
little off topic.
sure.
I think I had like a Wellbutrin ingestion like a couple of weeks ago.
Yeah.
So we recommended benzos and kind of the standard treatment, watching him on cardiac monitoring. But for whatever reason, he didn't want to give the patient benzos, and he just went with Keppra. Is Keppra a good second line, or do they usually go to like I was thinking too, because I don't think it's
Yeah.
just like the um. I mean,
This is for agitation or seizures or both.
yeah, for seizures, patient had like two seizures, and he was just like,
Yeah.
we'll just go with Keppra.
Yeah. Um, no. So there's a little bit of a push toward using Keppra. I would say that the evidence is non-existent. I am not convinced, like most anticonvulsants, Keppra generally stops the progression of seizures. Like if you have an epileptogenic focus and you want it to stop the spread of that focus to the rest of the brain, Keppra is a great drug. So are the other anticonvulsants, but um, with bupropion, you've got increased neurepi all over your brain. You've got lots of foci. The only way to treat that, in my opinion, is to hyperpolarize the whole brain. And the only way to do that is GABA. So personally, I would benzo, and then if that wasn't working, I would do barbiturates. Um, but I have found that Keppra has an almost cult-like following, and there are practitioners that are absolutely in love with this drug because it works great for non-tox seizures. It works really, really well, and Keppra cult. And it doesn't have all the side effects as we just saw in overdose, in therapeutic doses. It's a really safe drug. So what I would try to do personally in those situations is I can't tell you that Keppra is not going to work, but while you're giving the Keppra, can you also give GABA agent? And whether that is, I don't know if that person was intubated or not, but like whether that is benzos, barbs, or propofol, I don't really care. I just want their brain to be hyperpolarized so that it's not firing anymore, because that's what their seizures are. So it's hard for me to say to a practitioner like Keppra is not going to work. I don't really know that. I hope it does. That would be awesome, right? Wouldn't we all be excited if Keppra was like magic for tox-induced seizures? There's not enough data to say that it doesn't or doesn't work. So I would say we recommend benzos or barbs. If you're going to give Keppra, can you also give benzos? And certainly if the Keppra doesn't work, please switch to benzos. And then, if they're not familiar with barbs, then get the MPU on the line. We'll talk to them about that. Does that answer your question?
It does, thanks. Yeah, we
Yeah.
did get MVU on the line. They are very, very polite. Our MVU are great. They're very polite.
Okay.
But the doctor was very adamant about just like not giving benzos and just going with Keppra, and I think we
Yeah,
their
yeah.
decision. Yeah.
I know, and I have found there's a lot of them out there, and I don't know why. I think it's because, like in reality, like you give someone benzos for status epilepticus, they're going to be unconscious for 3 days afterwards. It's going to work great, but they're going to be, and so the critical care practitioners are very attuned to that. And same with barbs, they're going to be out for a while. Keppra is like, once you turn it off, they're fine. So I get why they're excited about it, but I don't know that it's going to stop the seizure in this case. So that's what I usually say. I usually just explain that. I just don't know if it's going to work. I can tell you that benzos and barbs will work. So if you're going to use Keppra, please also use benzos and barbs. And then, you can, and, sometimes I'll even say like, you might be able to use fewer benzos because you're using the Keppra, and that might be a sell for them as well. Great. Well, we went over an hour, so I want to stick to my word and say we're taking a break every hour. Let me just really quick take a look at because I think the anticoagulants talk is not that long. Yeah. Because I don't need a whole hour. Annie, I can call Zane. Zane's not on.